right, everybody, welcome back to another episode of the Fearcast. This is the podcast dedicated to OCD and anxiety spectrum disorders and getting your life back. I'm your host, Kevin Foss, and I'm a licensed therapist specializing in OCD and anxiety disorders. Thank you all so much for joining me for today's episode. This was a super fun interview that I've wanted to do for a while, and it took us a long time to try to get our schedules to work. So we're going to be talking, I'm going to be introducing Dr. Lorna Myers here in just a moment. But for those of you who are new, this is a question and answer based podcast. If you have questions about OCD or anxiety or anything, within the OCD and anxiety world, shoot me an email. Go over to fearcastpodcast.com and you can send me a message over there. I will read it, consider it, and likely put it up on a future episode. If you would like to cut the line of the backlog of emailed questions, go over to Instagram. I am Fearcast Podcast over at Instagram, and you can send me a DM, and just if you record your voice, you will go to the top of the list. The voice recordings are fascinating. They're fun. They're personal, and they add a little something special to the podcast. And that's why I really want to put those at the forefront for future questions. So, and to that end, if you have questions about today's topic, today we're going to be talking about functional neurological disorders, so FND, and more specifically, psychogenic non-epileptic seizures, PNES. So, let me introduce Dr. Lorna Myers in just a moment. She was part of a training I went through recently on FND, and she spoke so really clearly. She spoke with so much knowledge and experience. So I really wanted to have her on just to talk about what this is, and kind of why we'd be talking about it on the Fearcast, and also for those who haven't heard about it or don't know what treatment for it looks like. It can be, one, if you see it for the first time, it can be quite the surprise and scary and worrisome and all that. So knowing that there's a name, knowing that there's a treatment for it can be really encouraging. And so I just wanted to throw this out there for anybody who is interested. So let me tell you about Dr. Myers. So Dr. Lorna Myers is a clinical psychologist and the director of the Psychogenic Non-Epileptic Seizures program at the Northeast Regional Epilepsy Group in New York and New Jersey. She has worked with patients diagnosed with psychogenic non-epileptic seizures for over 20 years. She's also the author of a patient guide, Psychogenic Non-Epileptic Seizures, a guide, and for clinicians who are seeing their first PNES patient, the Psychogenic Non-Epileptic Seizures pocketbook. So, without further ado, here is my conversation with Dr. Lorna Myers. Dr. Lorna Myers, thank you so much for joining us for the Fearcast today. We're excited to hear about FND, PNES, and what those acronyms mean.
Thank you for inviting me to be here with you today. And yeah, we can start just by defining what all these letters mean, right? We talk about functional neurological disorder, FND. That's what that means. PNES means psychogenic non-epileptic seizures, and they fall under the umbrella of FND. They are also called functional dissociative seizures or functional seizures. So it's functional neurological disorders, and under that you have PNES or FS or FTS, and they all mean the same thing, okay?
Because we needed more letters.
Of course, we did, yeah.
Of course. So, awesome. Well, I appreciate you sharing it and just kind of defining those terms. So for those who don't know what FND is, functional neurological disorder, can you explain a little bit about what that is, what that looks like, and what the experience is like for this disorder?
Sure. So functional neurological disorders is really a relatively new term, and this would cover many of the medically unexplained symptoms or diagnoses that have been sort of going around to different doctors and not really being picked up on properly or treated properly. So you have a whole variety of symptoms that might appear with functional neurological disorders, for the most part, many of them are neurological. So you might have, for example, paralyses or tingling or different sensations in the body, different parts of the body, as well as headaches. But also you have some other things like gastric issues as well, sometimes vocal issues. And one of the other symptoms, which is my specialty, is the seizure symptom. So that would be one additional symptom that is a bit unique in that patients with non-epileptic seizures don't have all of the same characteristics that patients with FND have, and they're treated a bit differently than many of the other FND symptoms.
Okay. Let's see here. Could you tell us a little bit about? So you kind of said they're a little bit different. How do those seizures differ? I think we talked briefly about this before. How do those seizures differ in appearance and duration than other seizures?
Yeah. So non-epileptic seizures or psychogenic non-epileptic seizures can look so much alike, so much like a epileptic seizure, that you could be a really seasoned epileptologist, and just by observation, you would not be able to tell the difference. They present a lot like a generalized tonic-clonic seizure for the most part, but then they can have some other presentation. So usually you'll have an alteration of consciousness or possibly loss of consciousness, and then you'll most likely have some sort of motor involvement. It could be a part of the body that is shaking or the entire body that is shaking. And typically it lasts a few minutes, but it could go on much longer than that. There used to be a myth that with non-epileptic seizures, patients tended not to injure themselves because there was also a myth that they were sort of voluntary. But I have plenty of patients who have injured themselves, and pretty seriously. So, that is not a one way to sort of distinguish one from the other. The only way you can really diagnose PNES, non-epileptic seizures, and rule out epilepsy is through some pretty high-tech testing. It's called video EEG monitoring. It's typically done in the hospital. It involves a 3 to 5 day stay. The patient is hooked up to EEG leads, and they have a camera that's on them. So that way the doctors can actually see when they have a seizure, what does it look like on video, and what is their brain doing? And if it's not consistent, then you would probably go with the diagnosis of non-epileptic seizures. They also need to get as many episodes as they can so that they have a good sampling and they know, okay, we've captured all of the typical episodes and they are all non-epileptic. Now, I will say that now it's a little easier because there's something called ambulatory video EEG monitoring, which can be done at home. And so then you come into the outpatient office, you get hooked up as well to the EEG. You take a little camera home with you, and then you have that for usually 3 days. And then you bring that back and all that information is there, and then it gets read. Yeah. So that's called the gold standard for diagnosis, video EEG monitoring.
How available is this equipment? It sounds like something that wouldn't be readily available at most hospitals.
Yeah, in the U.S., it's actually more available than you would think. And there's something called the National Association of Epilepsy Centers, NAEC, where you can actually type in your zip code, and it'll sort of show you all the places near you where they have this type of equipment. You're looking for what's called a level 3 or a level 4 epilepsy program. So there's plenty. I'm sure there are some places where there aren't, but then you also have the ambulatory video EEG that can also be used. Now, if we were talking about other countries, for example, South America has a real scarcity of video EEG equipment, and sometimes there's only a few in an entire country.
Okay.
I'm actually from Argentina, so that's why I know, because I've gone and done a number of conferences, in different South American countries, and that's a major issue. Yeah.
Okay. So I've got like all these questions I want to ask all at once, and my brain is just not working to get all of them at the same time, unfortunately. So I guess we'll go with this one. So how does it start to develop? Because where does it come from? At what age and at what age does it typically start to show up?
Yeah, it's a great question, because what we know is that typically patients develop non-epileptic seizures between 20 and 40 years of age. But there's a good number of patients that develop them in their teen years. So they're very similar, but they're treated somewhat differently. And that's important to know, that typically get them in adulthood. The other thing that we believe is that a very common risk factor is trauma or life adversities. But the trauma doesn't always happen right before the seizures start. So initially you might have a traumatic or multiple traumatic events, and then possibly some years later, you develop non-epileptic seizures. Almost as if the trauma has, it's a wound, it has perhaps not been treated, it's sort of stayed there. And then often these patients have been juggling so many activities, so many responsibilities for many, many years, sort of plowing ahead, moving forward, not giving themselves the time to stop, to rest, to self-care. And then X number of years later, that first seizure erupts. And when that erupts, you often have sort of like an avalanche where you have a lot of seizures, in the next few weeks or months. So that's in adults. Now, in teens, trauma does not seem to be such a big risk factor for them. And instead, what you see is a lot of times there are more sort of chronic stressors for that age group. So, for example, things that have to do either with school, so either learning difficulties, perhaps bullying, perhaps family issues, either discord or there's been some movement, maybe moving from one place to another, changing schools, families having some internal sort of issues as well. And so those seem to be the risk factors for teenagers.
Okay.
And they're treated differently. There are some very specific treatments for adults, and for teens, the treatment is much more sort of family oriented and working with the school and working with the teen, obviously.
Yeah, you mentioned in adults it can start after some time after a trauma. Is this something that's more common within like PTSD responses, or folks who are who serve in the military, or is that higher in that population than others?
Yeah. So I should say that 80% of patients who are adults who develop PNES have had some sort of trauma or life adversity.
Okay.
And then we have a 20% we should talk about later. There's a 20% that don't, and they're a little different. But the 80% that do have trauma, around 40-50% have PTSD. So they will actually be able to be diagnosed with both non-epileptic seizures and PTSD. You do see it in military, and there's been a number of publications coming out of VAs. But you also see it it's a higher incidence in women. And so in women, you usually, if there is trauma, often it's a sexual trauma, domestic abuse, that sort of thing, that is very common. But then also, we've sort of widened our view of adversities and PNES. And you'll sometimes see that it has either to do with medical trauma, sometimes an accident, a major injury. So it's much more, I would say maybe 20 years ago, we used to think that we were always asking for sexual and physical abuse. And that was sort of what we were focused in on. And now we've realized that it's almost better to ask an open-ended question, sort of throw a net out, and then you will sometimes see things that have happened that wouldn't have fallen in those two categories, but they're obviously, qualify as adverse, and sometimes severely adverse. Yeah.
So kind of looking more broadly as to what could be considered a trauma or an adversity in someone's life.
Yes. Yeah.
Okay. Yeah. So oh man, there was my question and then it just went away. This is how today is going to go. So not my favorite day, but it's the way it's going to go. Okay. So, all right. So when it starts to develop, I mean, someone starts to, they're experiencing something that appears to be seizures. They're going into their doctor. They're going to make a referral to this test, the gold standard test, right? I suppose my question is getting into that, like, what does treatment start to look like, and how does that treated either medically or how is that treated psychologically through maybe more behavioral treatment or behavioral methods?
Yeah. So we start with that gold standard because it would look very different if they had epilepsy, where the treatment would be medication, possibly some devices that are now used, possibly epilepsy surgery. So it's really important to know. And like I said, since they look so much alike, you really need to be sure that you're treating this person who has these seizures with the correct treatment. For non-epileptic seizures, the treatment is not medication, is not surgery, obviously. It is psychotherapy. But it's typically psychotherapy that is tailored to treat the seizures. So the seizure is your target symptom. And no matter whether you're using cognitive behavioral therapy or mindfulness-based therapy or prolonged exposure therapy, if you're working with someone with PNES, it should be tweaked. Because you're looking at your target symptom is seizures. Every week you should be checking that symptom to see if that's getting better, because that's sort of your gold standard, I guess, for the treatment is, your hope is that they will finalize the treatment with no seizures. You're also using certain tools. For example, a seizure log is really typical no matter what modality you use. Typically, you're also going to want to have some relaxation exercises, some grounding exercises, and in that sense, all treatments have those basic ingredients if you're treating non-epileptic seizures. You're also focusing a lot on emotional regulation. That is one of the big problems, I think, with non-epileptic seizures is that there is a tendency to dysregulate emotionally and physically. They tend to be sort of disconnected. Yeah,
and that was kind of my crash course in this when I first heard about FND. It was kind of explained to me as, it's like someone's going through this stress, and the brain kind of goes through this bottleneck of like not quite knowing how to deal with it. Now you might be hearing my explanation going like, you were told wrong, and that's okay. But it was explained as the brain doesn't quite know how to deal with the highs and lows and putting all those feelings and experiences into their proper place. So it kind of has a meltdown, or it kind of freaks out in a way. And that's the resulting what appears to be a seizure is the brain just not quite knowing how to handle it. Now, is that completely wrong? Am I completely off?
No, I think that's an accurate way of explaining what happens. I think that what happens, especially with non-epileptic seizures, you see that there is the limbic system, right, reacts to it. Basically, there's sort of like a fight or flight mechanism that gets activated, either because there's an emotional issue, a conflict, or even, for example, excruciating pain, or not being hydrated all day. So there's a reaction, there's a stress to the body, to the mind, that sets things off. And so you set off this fight or flight, and really quickly it connects to the motor area. And so you have this like that, and you suddenly have a seizure. And what's missing is that part of the brain that would sort of look at this and say, okay, what happened just now? When I had this argument, what happened, internally with me? What could I have done differently? So you've got sort of that, if we're talking about neuroscientifically, right?
Yeah.
The prefrontal cortex is not functioning in this scenario. And you just have fight or flight, and you have the motor area that goes off. And so stressors can be, like I said, because we used to think, it's emotional stress only. But we actually now know that these patients are really disconnected from their bodies. They will sometimes go for hours without eating, or hours without having water, or they work straight through. They're really good employees sometimes, not everyone, but, I've had plenty of patients, who were the best employees because they don't complain and they work, until they drop.
Yeah.
So there's that disconnect with the body, and there's increasing stress, right? Increasing physical stress, but also emotional stress. And it's almost like they don't pick up on the signals. Sometimes it's like, when your car gives you the check engine light, that you just keep driving and you just keep driving until finally the car stops. And with these patients, you'll often see that they just don't pick up on a lot of these signals. And then at some point the seizure happens. So once they start to be able to engage their prefrontal cortex, right, to be able to say, okay, so did I eat today? Or when I just had that conversation with my mom and she said that, that really sort of hurt me. What happened there? And to actually be able to put words to the feelings, right? To say that hurt me. I was really sad when she said that, because that's the other disconnect. We talk about alexithymia, right? That there's like a not being able to name your emotions. Not being able to really. You'll ask someone, "Are you stressed?" And they'll say, "No." These patients in particular will say, "Honestly, no, I'm not stressed." And then you hear their day and you're like, how are you not stressed? I mean, that is a lot. But so there's that disconnect with emotions, disconnect from the body. Yeah.
Yeah. It's so interesting when you said, they'll go all day and not drink water. Right. And we typically not think about that as a unique stressor, but obviously it's going to have a tremendous impact on the body. And kind of as you're talking about, there's this kind of bypassing of that kind of understanding there's that disconnection from the body, or disconnection from like what your body needs. So it is not going to handle that well. So it sounds like, through behavioral therapy or through kind of CBT or, other talk therapy methods, really trying to expand on like what was going on during that. And I hear like that's where that seizure log really comes in handy is, all right, this seizure happened. Let's break it down to what was happening before this. Were there stressors? How was your day? What were your interactions with other people like? And really trying to hone in on that. So to that end, are there, for individuals who are struggling with FND, do they then have similar common patterns that tend to lead into episodes? So, for example, is it a disconnection with eating or drinking, or can someone be more particularly sensitive to family stress or to social interaction stress, or is it just kind of commonly, or is it just more diffuse than that?
Well, with FND, I would say that there is also the disconnect with the body, the alexithymia, are things that you definitely will see across the board, no matter what sort of presentation you have. There's a tendency for somatization, obviously. So those emotions, if we're going back to psychoanalytic, terms, there is really a conversion of that emotion or that strain into something physical that from let's say the ER doctor is not making sense of this. They're just not comprehending, why is this person coming in with this paralyzed arm?
Right.
No medical explanation for this. But, often there is that disconnect, that detachment, that tendency to somatize. And again, the work that, with FND in particular, it's a little different in that depending on the symptom presentation, sometimes in addition to psychotherapy, physical therapists and occupational therapists also have a role to play. But for the most part, even with physical therapy or OT, they're bringing in some ingredients of CBT into the work that they're doing. So that's what I would say about FND and that detachment from the body, that tendency to somatize. Yeah.
And so you said something really interesting there as well that I want to highlight. So you said there was to go back to the psychoanalytic language and the conversion, right? This was historically known as conversion disorder. Is that correct?
Yes.
Okay.
Yes, that is correct.
Yeah, because I think a lot of times, for the older folks who are listening, that's how it was initially, discussed or diagnosed. It's this conversion. It's like someone can't use their arm, or they all of a sudden lose their sight. There's no explanation for it, and it's an anxiety thing. So having more information about it, it kind of breaks it down into what this actually is, right? So, and to that end, we're not just talking about non-epileptic seizures, because it can present as loss of motor function, loss of sight, other things. In other ways, what other ways can it appear in that sort of fashion? Like, how, in other ways, can it affect the body other than the non-epileptic seizures?
Yeah, it'll what you just said, loss of motor function. So sometimes there's paralysis of a part of the body or of the whole body. There might be sensations, sort of tingling sensations or unusual sensations in different parts of the body. Sometimes patients will have tingling in the hands or tingling in the feet, or just an odd sort of, almost ants crawling, that could be that someone would present with. Sometimes a loss of speech, mutism or stuttering, which has to be checked, because is it stuttering or is it psychogenic stuttering or functional stuttering? You can have that. You can even have, I've a few patients that I've seen had psychogenic blindness. So they lost sight for a while, for a period of time, let's say an hour or two, and then it came back. So all of your senses could be affected, sight, hearing, etc. But they are functional because this episode starts and then perhaps ends, and there's no medical explanation for why that happened.
What's a common length of time, or is there a common length of time for loss of sensation, loss of function?
So I specialize only in the seizure department.
Okay.
So I wouldn't know so much about the other functions, but in terms of seizures, I've seen anything you can imagine. Sometimes they last seconds. And then I've had some patients be in an episode for 10 hours.
Yeah.
So it really depends on the patient. There are different types of episodes that the same patient can have. But sometimes they can go on for a really, really long time. Yeah.
For someone who's having the seizure aspect, you kind of said they can have different presentations of the seizure. Do those tend to correspond to, certain types of stressors, or is it just luck of the draw in that moment?
Yeah, that I wouldn't know.
Okay.
I don't think anyone has looked at it, from an empirical point of view. I know that at one point they were looking at if the seizure was more intense, more physically intense, did that correlate to certain aspects of, let's say, historical trauma or not? But I don't think they ever really concluded anything. It was just some of the seizures, and I will say this, can look a lot like a reenactment of trauma. So perhaps someone was raped, and when they have the seizure, it may look a lot like a rape is happening. This may be mixing with a flashback, but in that sense, I think there was a question at one point: do some seizures, could we sort of say that if someone was a victim of sexual assault, would their seizure look one way? But none of that ended up finding any sort of firm conclusion.
Never
I
panned
think
out.
it sort of moved into that. Yeah.
Interesting.
Yeah.
I was interesting. I was talking to the missus about something like that recently, where there should be a place, and I don't know if they already have this, where quote failed studies go.
Yeah.
So we kind of, know what they've tried and know it's not working, so we can kind of go in a different direction. That's an entire side note.
Such a good idea. No, but that's such a good idea. It's true. Failed studies and then replicated studies, right? Which often are hard to get published, because, no one wants to publish something that's already known. But I mean, it's so important, right? To know that what was said was actually, confirmed again.
Well, perhaps that's another avenue for you to look into, or another website to start for you, I suppose. Or I'll get the missus to get on that. She won't. But okay. So getting back to this, so in the seizure, so let's say now someone is experiencing an episode, right? What do other people do? I know we talked a little bit about this just before we recorded. What do people on the outside do to kind of help someone either through that? Because if someone is experiencing what appears to be a seizure, that can be, that can be incredibly frightening. I mean, certainly to the individual, but also to family members, clinicians, teachers. What can someone who may be listening to this do to help someone who's going through an episode?
Yeah. So there are different scenarios, right?
Yeah.
It's one thing if you're at home and you're with a caregiver, someone who knows you. Very different if you're out of the home, surrounded by strangers. So there's a few things I can say. Okay. A lot of times I will ask the patient, because they're experts in their seizures. Like I said, everyone has different presentations. So I'll ask, is there anything that has been done so far that has been helpful? And some people will say, I just want, the best thing is for someone just to stay with me and not say anything, just so I know I'm with someone, but they're quiet. Some people will say, I want to be left alone. It's better when I'm alone. Or I like for someone to speak to me, slowly, calmly. Yeah. So I would say a good place to start is to ask the person, have you noticed anything that is helpful or not helpful? Some patients, they're unaware, during the whole episode. So they won't be able to tell you anything. They'll say, I don't know, it doesn't matter to me as long as I'm safe. What I would say to caregivers is, yes, initially it's really scary. It's scary to see a seizure, but it's super important to, one, understand that these are non-epileptic. So there is no risk of, and this is if they've been confirmed to be non-epileptic. This is why I keep going back to the gold standard video EEG testing.
Yes.
So we know that they're non-epileptic. So then we know that they can go on for an hour. And there's no risk of brain damage. There's no risk of lack of oxygen. Sometimes, a caregiver will say, well, it looks like they're holding their breath, or it looks like, they're maybe at risk of not breathing. But if they're non-epileptic, they should be fine. They could go on for 10 hours and they should be fine. They're going to be exhausted. They're going to be, wiped out, but there's no danger of death unless they've injured themselves. This is the other thing. That's the caveat. If they've fallen and hit their head or something like that, then that may be, you're outside of the realm of non-epileptic seizure. Now you're in a head injury.
Right.
So then you would call 911. Usually I say, don't call 911 unless there's been an injury or unless it's going on an extremely long time that is really sort of worrisome, or they look really different. And they look really different is because there's around 20% of patients who have non-epileptic seizures who also have epileptic seizures, just to make this a little more complicated, right?
That's what we're here for, the complications.
Yeah, exactly. So if the seizure looks really different than anything they've seen before, then that might be a moment to call, to consider calling 911. But other than that, usually don't call 911, because in the ER, they really don't have anything to do. They don't know what to do with the patient. Sometimes they're really rude and dismissive of the patient. And then you're left with a bill, a big bill, for the ambulance, for the ER. And so, patients who sort of know their seizures and their caregiver knows their seizures, they typically opt to write it out. if possible. But sometimes there's a multitude of seizures in one day. There can be reasons why you would say, okay, I am used to this, and I do know what to do, but at this point, I'm going to actually bring in a medical professional. But then what I would say is to remain calm, as hard as that is, to remain calm, and to basically just make sure the person is safe. Make sure that if they're banging their head, they have a pillow under their head, that they don't have anything around them that's really hard or that, has points that they might injure themselves against. And then to stay there and just watch over them, unless the person says that they don't like being watched, that they don't like anyone there. That's basically what I do in my office. If someone is having a seizure, then, just make sure that they're safe. If they come out of the chair, let's say they're on the floor, make sure there's a pillow under their head. I usually just speak and say, so-and-so, you're in my office, you're having a seizure, you're going to be okay. It's going to pass. And I'm here with you. And I just sort of repeat that, sort of like a mantra. Until they start to recover. And then you see, this is the other thing I will say. Sometimes therapists will, once the seizure happens, they encourage the patient to leave, even if they've recovered, because it sort of feels like, oh, they've had a terrible seizure. We can't continue the session. Again, ask the patient, because some patients will say, you know what? It's a terrible seizure, but after 2 minutes, I'm back. And I really wanted to finish my session, and I don't need to go home. So ask the patient. I usually ask. I say, "How are you? Do you feel you can continue the session?" And then we'll see. We'll see what they say.
Yeah. I think that really goes back to trusting that they have the lived experience. They've been themselves for a long time, and unless it's, I can imagine it's if a PNES diagnosis is brand new to them, and in which case they do need a little bit of understanding, growing to know what the symptoms are, what this feels like. But sooner or later, it sounds like they'll start to recognize what it feels like and what is helpful for them. And to that end, is there any advice or guidance for someone who is in the middle of it? What tends to be helpful in terms of dealing with the episode? So the person who's experiencing that non-epileptic seizure, that's a knowing smile. It's a mouthful. I'm not the first person who's stumbled on that one. But they're having that. What are some things that they can do that can be generally helpful, and what are some things that they can do that are just really unhelpful?
So I would say that some of the work that we do in therapy is actually geared to providing patients with certain tools, because you initially, when the patient will come to you, they really are at a loss. There's very little that they can do during the seizure itself, and it feels like it just comes upon them, and it's sort of uncontrollable. It's like it seizes them like a seizure, right? So what you typically will see is that that's how they present. And with treatment, you're teaching them certain tools. So that's why you teach deep breathing, or you teach bilateral simulation, or you teach certain trance exercises. And that's something that they can start to use with their seizures, especially if they have an aura, if they have that pre-signal where they feel, oh my gosh, it's coming on. Then once they've practiced with, let's say, deep breathing for several weeks, that's something that they can start to use. And initially, they're going to feel that it doesn't do anything. Initially, they'll say, I tried the deep breathing, but it didn't work. And that's fine. You keep at it. And what they will see is that over time, the seizure almost sort of pushes off a little, and then it still happens. But if they keep using those tools, at some point, the seizure goes away. And I always say to them, you're not pushing. It's not like a fight with a seizure. You don't want to push it off with force. You use the tool, you regulate, and the seizure drifts off. Because I will say, if you fight it off, it often comes back worse. It has that tendency that you're dysregulated, you're fighting off this seizure, this symptom, and it sort of rebounds. So you don't fight, but you do learn how to regulate, and it drifts away.
Yeah,
that's the goal.
Yeah, it's the way that we're talking about it here. Really, it's similar to the way we might talk about dealing with an obsessive spike. For a typical FearCast listener, we'd be talking about OCD and dealing with the obsession coming on. It's we acknowledge that it's happening, we know that it's there, but we're going to choose to disengage. Right? Yeah. Not shutting it down, not fighting it or tensing up against it. We're like, all right, it's here. I'm gonna ride this wave. It's going to be 2 minutes. It's going to be 20 seconds. It's going to be 2 hours. I don't know. But that's where we can. So is that where, to a certain degree, disengagement? Is it disengagement into kind of nothingness, or is it re-engagement into? In other words, trying to refocus attention into a conversation, into watching a show. If you're let's say that someone has they're having either the non-epileptic seizure or they lose function in their arm. Is that all right? I'm gonna try to disengage from this experience by watching a show, having a conversation, getting back to work.
You could. I mean, sometimes distraction will work. Okay. But I think for the most part, what you're aiming for is regulation. When the seizure starts, it usually starts because something has dysregulated the system, stress. Right?
Okay.
And it's stress, it's hunger, it's something. Yeah. And so you don't want to become panicky about the seizure, which happens, where someone will say, oh my gosh, I'm having an aura, I'm going to have a seizure. And once you do that, you're dysregulating even more.
You're adding
and so
to
then
it, yeah.
100%, right, the seizure is going to happen. So what you really sort of focus on is the regulation. That's why you use all these different tools. You also use grounding, holding ice, or focusing in on certain objects in the room and naming them. So you're regulating. And when you regulate, when you're doing that, you're not feeding into the seizure, you're not feeding into the panic.
Right.
That's when the seizure goes away. That's when it doesn't happen. So it's all, in my mind, it's all about regulation. And once you learn how to do that, then you've mastered, the seizure, which for patients can seem really impossible, right? Because they might come into your office and they're having 10 seizures a day. How is it possible that I'm going to, master this? But it does take work. But once you really practice and overlearn these different tools and you practice with them and you choose, okay, this one I really like, this one I don't like so much, once you have that, yeah.
And I think that's a really, really good point for a lot of, for everyone to be hearing is that, you list off a lot of different tools just very, very rapidly, and we could go into each and every one of them. We are not, but all of those are individual skills that one can learn that do help regulate somebody. But they're not magic, all of them, and they're not magic for you. Some of them are going to work more than others. Like and I've talked with my clients. Sometimes deep breathing is going to look different for a lot of different people. Where some people are going to prefer one method, and other people are going to prefer a different method. And it's not that this one is useless, but we got to go through them and try them and give them a good, honest try to see which ones are going to work for you.
Yes. Yeah. And the good, honest try, that's really important. And I will often say to patients that around 80% of patients who undergo tailored treatment for PNES do really well. But it depends a lot on the effort that the patient puts in. So if we're learning deep breathing and I ask the patient, now for the rest of this week, practice in the morning and at night, practice it religiously. This is a prescription. And if they come in the next session and they haven't, that's an issue.
Yeah.
Because they're shortchanging themselves versus if someone comes in and says, I didn't practice it twice a day. I practiced it 3 times a day, and this is what I noticed. I noticed that when I breathe this way, this happened. That person is very likely to do better because they are really invested in it. And it's not, that we're sort of saying like, oh no, it's the treatment works, but it really does have a lot to. It's the same as if you go with a personal trainer, right, to work out, and if you only meet with them once a week versus if you during the week also do your reps, right? It's similar, yeah.
And it's boring. It's boring and it's slow and it's tedious at times. But as with everything, I mean, I threw my back out a couple of years ago, and it was 10 months of everyday pain and then going to a physical therapist. And it was, you get better when you do the exercises, right? Yes. And listeners to the show also know, I will throw my back out again because you do your exercises, and then when you feel better, you stop doing them. And you wonder why it comes back. So these are continual things. I'm assuming the same is going to be the case for PNES, is that we're still practicing regulation even when, because as you said, like the goal of treatment in this case isn't a reduction of anxiety like we would with ERP. We're talking about a reduction in those seizures. So it's just because they're gone doesn't mean that then you're fixed and you never have to practice these things again. We continually practice.
Yeah. It doesn't mean that you can now slide into no self-care, right?
Right.
Or you can overload yourself with 3 jobs, which sometimes happens. This is the thing, right? Sometimes I will get a call from someone 2 years later that they've had a breakthrough seizure. And typically it takes one phone call to sort of go through, okay, what's been going on with your life? What have you been doing? And they will themselves say, you know what, I realized that I actually forgot everything we talked about and I'm way overdoing it and I haven't done my deep breathing. I don't even remember what is, so you remind them, and say, okay, these were the tools, remember? And then they leave and then they don't call me again. Right.
Yeah.
So that's very typical. I mean, that's human nature, right? That from time to time we need a tune-up or we need a reminder.
Yeah, and I imagine the conversation with those breakthrough seizures, or a relapse, as it were. There's a lot of sense of failure, but it's people stuff, right? And it's life stuff. We're going to have you're going to have stressors in life. You're going to lose track or disconnect from some of the things that are helpful for us, and it's no time then to beat yourself up. It's all right. I'm just going to get back on the horse and keep pushing.
Yes. Yeah, usually it's sense of failure and sense of panic, because there's a fear that the symptoms will come back, which is what we want to avoid, right? Because panic leads to dysregulation. So I think that session with me is just sort of a reminder and bringing the patient back down, to balance. You can do this. You did it. You did it for 2 years. And that's the best indicator that you can be better.
What's the ideal and what is the expected outcome of treatment for PNES?
So the ideal is no seizures ever again. And you would be surprised, but there are a number of patients who have no seizures ever again. Then if we're talking statistically, we would be looking for significant differences. So if someone was having 10 seizures a day, and now they're having 1 to 2 a month, that's a statistically significant improvement.
That's pretty stinking good.
Yeah, they're still having seizures, but it is a huge difference. But it's also subjective because for some patients, 1 seizure in a year is too much. This is the same with epilepsy. It's subjective. And perhaps the seizure, for someone else, 1 seizure a month is okay. They're actually, very pleased with that. But yes, the goal is no seizures. I sometimes think if someone is still having a seizure or 2, even after they've gone through treatment, then perhaps to consider another modality. There are other treatment approaches. So if you've done CBT and you did well, but you're still having seizures, then perhaps MBT, mindfulness-based treatment that's tailored for the seizures, or perhaps do group psychotherapy for non-epileptic seizures, which also exists.
Yeah.
Yeah.
I think that's great. I think it's great advice. That idea that you can try different modalities, and if one thing has worked, but you're still missing something, you can try something else, and hopefully that will kind of shake out something loose or kind of illuminate another area to work on.
Yeah. That's the hope. Yes. Yeah.
That's the hope. Mm-hmm. Well, I know we're getting to the top of the hour. I don't know what your timing was like, but
yes.
But is there anything else that we missed, or anything else that you'd want to share about FND or PNES, treatment of it, or if there's just any advice that you'd want to give to someone who may be listening to this and maybe struggling or scared?
What I would want to mention, there's a website that's for patients, and clinicians also visit it. It's called non-epilepticseizures.com. And I would recommend, that's a very good resource. There's a tab for referrals. So sometimes when patients are looking for a clinician who has some experience with PNES, they can go there. You might want to be listed there at some point, if that's in your interest. But there's also books and, different resources, different other websites that they might also visit. So that's what I would leave with. And there's a section for clinicians, articles that they might want to look at.
Awesome. Okay. And is there any information or any articles from you up there?
I'm sorry?
Any articles from you up on that website?
There are, yes, of course. Well, it's my website, so yeah. Those are the ones that I know the best. But actually, there's a bunch, because they're sort of split up by sections. And so, everyone who works with PNES pretty much sends me their articles when they're published so that I can post them up there. Yeah.
Fantastic. All right, good. That's what I wanted to know. I always want to know, for someone who may be listening to this, who wants to know more about you and where to find information about you. So if you are out there and listening to this podcast or watching this podcast, as it were, and want to know more, you can go to non-epilepticseizures.com, correct?
Yes. And there's a contact button, and it actually goes straight to me, believe it or not. It doesn't say that,
Perfect.
But it goes to me. Yeah.
Perfect. Yeah. Awesome. Well, thank you so much for your time, and thank you so much for sharing all this information about this. Again, I don't think this is talked about enough, not enough information out there, so I appreciate all the work that you're doing.
Well, thank you. Thank you for inviting me, and thank you for giving PNES a platform.
Absolutely.
Thank you. Bye-bye.
Thank you for listening to the FearCast. If you would like your question answered on a future episode, please click on the Submit a Question link at fearcastpodcast.com. If you would like your question answered sooner, please send me a recording of your question to questions@fearcastpodcast.com, or by sending me an audio message through Instagram by DMing me at fearcastpodcast on Instagram. If you like the FearCast, please write a review on your podcast platform of choice. Please remember that the FearCast is not a substitute for psychotherapy. If you need a little bit of help in your recovery, please go over to fearcastpodcast.com and click on the Find Help link, and there's going to be some information for you there. So until next time, take a risk, challenge yourself, and don't take your brain too seriously. Bye.